basically male infertility is very difficult to treat because there is very little which we can do to help the patient other than deciding whether his hormonal level is normal, or we are happy if we find the varicocele because at least we can do a varicocele surgery to improve his this. The third line of treatment is that you do the varicocele surgery or you give hormones, and the third line of treatment is after their sperm count is improved, you have to tell them when to have sex.
सर्जरी सिंप्लीफाइड, शस्त्र कला सरल शब्दों में।
हेलो एवरीवन, वेलकम बैक टू आवर चैनल सर्जरी सिंप्लीफाइड, शस्त्र कला सरल शब्दों में। मेरे साथ है डॉक्टर निखिल।
नमस्ते।
तो डॉक्टर, आज हम कौन से टॉपिक के ऊपर डिस्कस करने वाले हैं?
यूरोलॉजी सीरीज में हमने अभी तक 2 सिम्टम कवर किए। एक पेशाब जब रुक जाता है और पेशाब में जब खून होता है। So today we will discuss male infertility, मतलब बच्चा पैदा करने में जो दिक्कत आती है और उसमें जो हस्बैंड या मेल फैक्टर जो है उसके बारे में डिस्कस करेंगे because that comes under urology. फीमेल फैक्टर जो है that comes under gynecology. तो what is the definition of infertility? First of all, infertility is defined as inability to conceive a child despite regular sexual intercourse for a period of at least between 1 to 2 years. The earlier definition was 2 years. Now people tend to come for investigations and treatment even if for 1 year they have been trying and they have not got child. Now this is very important. It is not only that how long you have been married, because people may do family planning for some time, or they may not want a child in the early part of their marriage, so they use contraception to not have children. Sometimes, as very often happens in North India, many people come to Bombay to work or to Delhi or Bangalore. They are not staying with their wives except for a very short period in every year. So if they are not staying, then how is it that they will conceive a child? So the important point here is that they should be regularly having sexual intercourse. Still if they are not able to conceive. Now the important thing is here, conceive. That means suppose the wife conceives but it aborts. That also can happen. So they are not having child not because they could not conceive, but there is something which is causing the child not to grow till 9 months and become a fully grown child, and it is getting aborted. Again that comes under the purview of gynecologist. Okay. So therefore the deficiency, both these things are important. In male factor infertility, it is regular sexual intercourse but still not able to conceive. Okay. So basically infertility, as we all know, is maybe there is some problem with the husband, which is called male factor infertility. Maybe there is some problem with the wife, which is called female factor infertility, or maybe there is a problem with both. And the fourth category is there is no problem in either, still they don't have child, which is called unexplained infertility. Okay. So you must have heard people were trying for many years, they tried, they didn't get child, and then after 13-14 years suddenly they got child, and they got not one child, after they got 2 children, one after the other. So this happens sometimes that though they are having sexual intercourse regularly, both are normal, still there is no child. And then after some time when they give up everything, give up, okay, we are not going to have child, suddenly conceive. And not only one, then suddenly another one conceives. Now this is unexplained infertility, and there is no explanation for this or any reason what can be attributed, why it happens after 10-12 years of marriage, and then once it happens, why it frequently happens very quickly the second time. So now in male infertility, we have to first think of what are the functions, what are the different parts. Now you will be surprised, we have had patients who did not know how to have sexual intercourse. So first you have to confirm whether the person knows how to have sexual intercourse and whether he is doing it properly. that has to be confirmed, because in some cases we found that some were ignorant about how to do sex from the point of view of getting child. So that is the first. So that is some part of counseling in that. The second thing we need to find out is whether the person is getting an erection.
Okay.
So erectile dysfunction, which we'll cover in detail in another episode, or what we call often as impotence. People don't know outside, but when the person comes for consultation, we need to again rule that out, that he is able to get an erection and he is able to have sex. So these two things are very important. He knows how to have sex and he can have sex, both these things. So let us assume that he can have sex and he knows how to have sex, he is having sex regularly, still he is not getting a child. Now we come to male infertility, right? So in male infertility, the basic thing is a clinical examination, semen analysis and color Doppler. These are the three main things, and blood tests. So once we have established that he can have sex, the next thing we do is do a clinical examination and look for any blockages, for example, meatus is blocked or not, whether the prepuce is normal or not, or it is tight, it's not allowing the semen to come out properly, there's some obstruction. Then we see whether the size of the testes is normal, whether the development of the sexual characters, the size of the penis, everything is as per normal male. Is there any cross-leaf? Because you can make out, if suppose there is a problem with the testes is very small, or it is atrophy. What you call atrophy means it is very small and tiny and insignificant, which the patient may not know, because he has not seen anybody else's testes. So he does not know what is a small testis and what is a normal testis, right? So that thing is important, right? That whether his testes are normal, whether there is any pain, whether he has any small swelling. Sometimes in the epididymis, like this is the testis, on the top there is the epididymis which goes like this, gets converted into the vas deferens, and then it goes in the prostate and comes out through the penis, right? The testis, the epididymis. Now in this, sometimes there may be a cyst or a tumor or some infection or pain, tenderness. All these local factors have to be ruled out. Lastly, you can do a rectal examination to check whether the prostate is normal or there is any pain or swelling in the prostate. We are not looking for enlarged prostate. What we are looking for is prostatitis, that is infection in the prostate, which can also cause the ejaculatory ducts to get blocked. Right? So we are looking basically for any blockages in the passage from the testes up to the urethra, from where the semen will come out. Assuming all that is okay, suppose there is any blockage, then how do we prove it? We'll come to that.
Sure.
So assuming that there is no blockage, we find that's nothing. The next thing we do is a semen analysis. Now in the semen analysis, we have to see 3 or 4 things. First is the count. The normal count is 20 to 200 million per cc of semen. 20 to 200 million. Now, if the count is below 20, right, it is called oligospermia. Okay. If the count is 0, not a single sperm is seen, it is called azospermia. No sperm at all. So, in some patients you find that there is a oligospermia. In some people you find that there is a azospermia. Okay, that is one. Count. Second, count is there, but motility. Now the sperm has a movement because the sperm is deposited in the vagina of the female. From there it has to swim up the uterus and go into the tube or into the uterus, and the egg will come into the uterus, and there this will happen. The conception will happen and the child will get conceived. Correct? So it has to have the ability to swim. So that you check with the motility. The normal motility should be at least between 50 to 60% good motile for sperms. So for some, you will come to that, what are the conditions are. So if the sperm count is okay, but if the motility is not good, again it can affect this conceiving chances. The third thing we see is the morphology. Now each sperm has got a head, a body and a tail. So is it all the shape of all the sperms is normal, or there is some abnormalities, abnormal forms, either the head is broken or the tail is broken or something like that, right? And the fourth is necrospermia, means all the sperms are dead sperms, they are not alive. There's no movement, there's nothing. It's a dead sperm, necrospermia. So first was the count, second was the movement or motility, third was the morphology, and the fourth is whether there is two things: pus cells in the sperm indicating infection in the prostate. Because if there's pus cells, the infection is coming from the prostate, right? So pus cells in the semen, and the second is blood in the semen, and the third is fructose. Fructose comes from the prostate. So if fructose is positive, what it generally means is that the whole system is patent. Everywhere it is patent, okay? Because otherwise the fructose will not come, because it is a common ejaculatory duct. Alright, so it shows that more or less everything is okay. The fructose should be positive. Alright, there should be fructose. So this is in detail about the semen analysis. I forgot to say one thing. When we do the clinical examination, we also need to look for varicocele. Now what is varicocele? And how does it affect the sperm count? Varicocele is just like varicose veins in the legs. There are a bunch of veins which surround the testes, and they go up around the cord, and they go up and enter into the on the left side they enter into the renal vein, and on the right they enter into the inferior vena cava, which is the main blood vessel going down next to the aorta. The whole body's blood is going through that. So if there is any, just like in varicose veins, any kind of leakage of the valve, there is a valve where the testicular vein joins the left renal vein or inferior vena cava. If there is a problem, then the blood will go down, and both the testes the veins will get engorged like varicose veins, and they will drag the testes down. Commonly 95% of the times the varicocele is on the left side, not necessarily on the right. Sometimes it is on both sides. Very rarely you will get varicocele on the right and no varicocele on the left. Okay, because the left testicular vein goes at right angles into the left renal vein, and that is the reason why the chances of the incompetence being more on the left side, because it's vertical. So the pressure gets transmitted immediately. Here it is at an angle. Okay, so varicocele, what it does is just like in varicose veins of the legs we discussed, deoxygenated blood accumulates there, and because of that, whatever the decomposed products of blood are in that blood. So that blood is not pure blood. On top of that, it raises the local temperature of the testes by at least 1 degree to 2 degrees centigrade. Both these things, accumulation of toxic substances in the impure blood and the raising of the local temperature of the testes, causes a bad effect on spermatogenesis, and it can reduce the count, but most important, it reduces motility. So if you get a patient whose count is slightly normal or slightly on the lower side of normal, say 50 million, 40 million, not 200 million, towards 20 million, but motility is very bad, then varicocele surgery can improve the motility and they can have a better chance of conceiving. So just to summarize, in the clinical examination we look for varicocele, we look for any signs of obstruction to the path of the sperm like testes, then the epididymis and the prostate and the tip of the penis. Alright. After that, if there is varicocele, there are grades 1, 2 and 3. Grade 1 is you can only feel it. Grade 2 is bigger. Alright. And grade 3 you can actually see it. They are so big that you can see it. So between grade 3 and grade 1 is grade 2. But it is not important what is the grade. Even a grade 1 can cause oligospermia. So if you have a patient with infertility and his sperm count, especially motility, is abnormal, and he has a varicocele, then that is the best combination to do varicocele surgery in the hope that it will improve the sperm count and they will conceive. Now one way to confirm varicocele and all this, that means size of the testes, is to do an ultrasound and color Doppler. Color Doppler maps the movement of blood vessels. Like we do color Doppler for varicose veins, we do color Doppler for varicocele. Once that is done, then we of course, assuming that the female is normal, then we counsel the patient regarding everything. When to have sex, how to have sex. Though they sometimes say it is better, we counsel them. After that, if we find a varicocele, then we decide that whether to do surgery or not. Personally, I have done many patients varicocele surgeries, few of them have conceived.
Okay.
I wouldn't say that all of them have conceived, few of them have conceived, at least conceived or not. I know 1 or 2 patients who actually got children, but the others, the sperm count has improved.
Okay.
Motility became better, count became better, and so on. Okay. The third thing we do is that we need to also do, I told you, blood tests. So what blood tests do we do and why do we do it? The blood tests which we do are the hormonal levels. There are 3 hormones we want to test: testosterone level, FSH and LH, that is luteinizing and follicle stimulating hormone. LH and FSH, just like TSH was there for thyroxine, are responsible for release of testosterone from the testes. So it gives you an idea whether the azoospermia, that is the sperm count being low, is secondary to some problem like varicocele, or is it primarily testicular failure. So if the testis is atrophied, like I told you, when we feel the testis is okay, the testis is looking normal, but it is not functioning normal,
Right.
then what do we do? So if the testis is not producing testosterone, what will happen to FSH and LH? It will go up. So low level of testosterone with a high level of LH and FSH means this azoospermia or the low sperm count is because the testis is not producing enough testosterone, which is not helping in the production of sperms. Now such a patient won't need surgery. He will have to be given testosterone
Achha.
to improve his testosterone level, bring the hormonal level to normal, and then see whether the sperm count improves along with that. If that helps, then he may conceive.
Okay.
Alright. If suppose the testosterone is normal, FSH and LH is normal, then it is secondary infertility, secondary to varicocele, or to infection, or to blockage. If there is a blockage, then you can do a surgical correction. So you can join the area of the vas deferens distal to the blockage to the area proximal to it, before that. So generally the blockage is between the epididymis, that is the cap, and the testes, generally. So then it is necessary to bypass that blockage by doing a surgery. Of course, these are all theoretical things. I have never done any surgery of bypass because it is very difficult to prove blockage. Theoretically, there is a vasogram. That means you inject a dye and do a study to see whether, just like you do put a dye in the urethra to see if there is any blockage, you can do, but nobody generally does it. It is only done in very specialized centers. Basically, male infertility is very difficult to treat because there is very little which we can do to help the patient, other than deciding whether his hormonal level is normal, or we are happy if we find the varicocele, because at least we can do a varicocele surgery to improve his this. The third line of treatment is that you do the varicocele surgery or you give hormones, and the third line of treatment is after their sperm count is improved, you have to tell them when to have sex. See, what happens is that the egg that comes from the mother comes around the 14th day of the period. That means you take the first day of the last period, not the last day, but the first day of the last period. 14 days from there, the egg is released. The egg will remain alive only for 2 days. So, assuming that the date is on the 14th, let us say 1st of the month to 14th, then 12th, 13th, 14th, 15th, 16th, this week, you have to have relations on alternate days. Because it could be that it is 1 day before or 1 day after. So, to take into that variation, they have to have sex on the 12th, on the 14th, on the 16th, or 13th, 15th, 17th, like that. 3 days with 1 day gap. Why? So that the sperm count improves. With a 1 day gap, it will improve. That is the way you ask them. And also, one more thing can be told, that the wife should remain lying down with 2 pillows under her hip, so that the sperm can, by gravity go into the uterus. So it will help even if the motility is little low, so that it should not come out. Sometimes some ladies complain that as soon as after relation they get up, the sperm comes out. So there is not enough time for the sperm to go into the uterus. So you have to advise the wife also to remain with 2 pillows under her hip and allow the sperm to go, give better chance for the sperm to go inside the uterus. So once the sperm goes inside the uterus, the better chance of conception. Of course, it also means that you have to, if there is a female factor, the female factor is to be treated by the gynecology colleague, and if both are there, then Both have to be treated. Now, what about azoospermia, where there is no sperms? There is a technique known as ICSI, intracytoplasmic injection of sperm. So what this means is that sometimes we can get a sperm even in azoosperm, means it is seen in the sperm report that there is no sperm, but if you directly tap the testes, you may be able to get a sperm, few sperm, because you need one sperm for this, right?
Yeah.
One sperm for conception. So you get a few sperms, you can then do test tube baby technique. That means you take that sperm, keep it alive in a medium, and then take the egg from the mother, harvest the egg from the mother, and see that the conception occurs in the petri dish in the lab. Once it starts growing, then take it and re-implant it into the mother's uterus.
Okay.
That way you can do. So there is around 25 to 30% success if you can get some sperm from the testes. If there is no testes, no sperm at all, ICSI is not possible, or it has failed, or they cannot afford, then the best way is to go for adoption. So that is in brief about male infertility.
Alright, cool. Sure. This is a very general topic which should be, discussed. Normally, they see this as like the women have like taboos when they have their menstrual cycle.
Yes, the
Infertility
tendency is
also,
to blame the mother if there is no
Right.
child, but that is not true. Both male and female factors are equally responsible. I don't have the exact statistics whether female factor is more or male factor is more, but I do some urology practice. I very often see male infertility patients.
Okay.
It's not that it's very pretty common in urology practice to get patients who have inability to conceive with low sperm counts or no sperm counts, means azoospermia or oligospermia. And varicocele I predominantly do only for infertility. I don't do varicocele for symptoms, though some books suggest that they question whether varicocele has any role to play in this, but in practice we have seen.
Right.
Patient was not able to conceive for years together. We did varicocele surgery, the sperm count improved and they conceived, and then they came for delivery also because my wife is a gynecologist. So we have seen in practice. Therefore, I am quite convinced that varicocele surgery does help. When there is nothing else to do, you can at least try it. It is not a very big surgery; it's a small surgery, and you just tie the vein which is going to the from there to the renal vein. Once you tie it, the varicocele is stopped, and then we have very often within 1 or 2 months the sperm count has improved.
Okay.
Yeah. So I think that it's worth trying. It's not a big surgery and it should be done. If there's a varicocele with the conditions of oligos, it's no use doing it with azoospermia. There should be some sperm. Some sperm should be there. As I said, motility should be the main problem, but some sperm should be there. Then there you get best results. If there's no sperm, then I tell them there's no use. You go for adoption, because most people who come to us, if they're poor, they can't afford this test tube baby, ICSI and all. We tell them. Then we tell them the cost, and we tell them that it's a 30% success. So if you want to try, you can try. So let's go and adopt.
Alright. Thank you so much,
Okay.
Doctor. So this has been a very interesting and very knowledgeable episode. So if you have any queries, you can let us know in the comment section. We'll be happy to get back to you on that. And do share, like and subscribe to our channel, and stay tuned for more episodes. Thank you.
Thank you.